All right, let's get straight into it. This is a high-yield review of tetanus, specifically designed to give you everything you need to know for your anesthesia final exams. We're going to cover this critical ICU topic from top to bottom.
So let's kick things off with a number that should really make you stop and think. We're talking about up to 1 million deaths worldwide every single year. It's a truly staggering figure for a disease that is, for all intents and purposes, completely preventable.
And that really brings us to the big question, doesn't it? How is this even possible? Well, to answer that, we've got to dig deep into how its toxin works, what it looks like in a patient, and the incredibly complex ICU fight needed to save a life.
So here's our game plan. We'll start with the big picture, the global threat. Then we'll zoom right into the microscopic level to see how the toxin does its damage. After that, we'll cover diagnosis, grading the severity, the all-important ICU management plan, and we'll wrap up with prognosis and the key takeaways you'll want to remember.
Okay, first up, let's get a handle on the bug itself and, where it sits in the grand scheme of things. So the bad guy here is Clostridium tetani. It's anaerobic, which just means it loves places with no oxygen. And its spores are tough, really tough. They're basically everywhere, soil, dust, you name it. They get in through any kind of break in the skin. Now, even though the vaccine is great, immunity can fade, which puts older people at risk. We've also seen outbreaks among injecting drug users when drugs get contaminated.
All right, let's zoom in, way in. We're talking about the microscopic level now, because this is where you see what tetanus really is. It's a full-on neurological assault waged by one of the deadliest poisons on the planet.
You see, it's not the bacteria itself that causes all the problems, it's the toxin it pumps out, called tetanospasmin. And its potency is, well, it's hard to even wrap your head around. Get this, just 240 grams of this stuff, about the weight of a small apple, is theoretically enough to kill every single person on Earth. So here's how the attack happens. The toxin hitches a ride on your nerves, traveling backwards, that's the retrograde transport, all the way to the central nervous system. Once it's there, it acts like a pair of molecular scissors, snipping a crucial protein called synaptobrevin. This single act prevents the release of our main off switches, the inhibitory neurotransmitters, GABA and glycine. And without those breaks, you get total chaos, uncontrolled, relentless firing of your motor and autonomic nerves. And this is the part you absolutely have to remember. Once that toxin binds to the nerve, it's game over for that connection. It is permanent, irreversible. There's no medicine that can undo it. The only way the body can recover is by slowly, painstaking, growing brand new nerve endings. And that explains why this illness is such a long, drawn-out battle.
So we've seen the how. Now let's talk about the what. What does this neurological storm actually look like in a real patient sitting in front of you? And remember, there's no lab test for this. It is a clinical diagnosis, plain and simple.
It all comes down to this classic clinical triad. First, you get rigidity. This almost always starts with the jaw. That's the famous lockjaw, or trismus, because those nerves have a short path to the brain. Second, you get these horrific muscle spasms. They are agonizingly painful and can happen with no warning or be triggered by the smallest thing, like a sound or a touch. They're so violent, they can actually break bones. And third, the really dangerous part, profound autonomic instability. And here's one of the most, well, honestly, one of the most haunting signs you'll ever see. It's called rhesus sardonicus. This grotesque, sarcastic smile is caused by the constant, unrelenting spasm of the facial muscles. It's a chilling look at the disease's power. And the spasms just get more intense. When those huge, powerful extensor muscles in the back and trunk get hit, they can force the body into this position, opisthotonus. This picture just gives you a sense of the incredible, painful force that patients have to endure. So you have a patient presenting like this. The next question is, how do you grade it? How do you assess just how bad the situation is? Well, for that, we use a framework called the Eblett classification. Think of the Eblett classification as a ladder of severity. Grade 1 is mild, maybe just some lockjaw. Grade 2, you start to see some spasms. But grade 3 is where things get really serious. The spasms are so bad they can stop the patient from breathing. And then there's grade 4. This is the whole shebang. You have all the features of grade 3, plus that severe autonomic instability, the so-called autonomic storms. And that becomes the single biggest challenge in the ICU. All right, we've graded the severity. Now, what's our ICU battle plan? The whole management strategy is supportive, and it centers on a logical, three-pronged attack. These are the three pillars. It's pretty straightforward, really. Number 1, shut down the factory. You've got to stop the bacteria from making any more toxin. Number 2, run interference. Neutralize any toxin that's still floating around before it can do more damage. And number 3, the main event in the ICU, symptom control. This is all about managing the life-threatening effects of the toxin that's already taken hold. So, to stop the source, you have to surgically clean out any wound and you give antibiotics. Now, listen up, because this is a classic exam question. We use metronidazole. Why not penicillin? Well, a key trial back in 1985 by Amiz, Shah, and Salim actually showed penicillin led to worse outcomes, possibly because it interferes with GABA itself. Then, to neutralize the toxin, we give human tetanus immunoglobulin. But remember, it only works on the free toxin, not the stuff that's already locked.
Okay, this slide is absolutely crucial. Managing those autonomic storms is incredibly tricky. You might think, high heart rate, high blood pressure. Let's use a beta blocker. Do not do that. Their use has been linked to sudden, catastrophic cardiovascular collapse, probably because you're leaving alpha-adrenergic effects totally unopposed. Instead, magnesium has become a true cornerstone of therapy. It works in so many ways. It dampens catecholamine release, makes the body less sensitive to them, and even helps with the spasms. It is a key player.
And that brings us to the end game. After weeks and weeks in the ICU, fighting this thing, what happens next? What does the aftermath look like? And what are the absolute must-know takeaways for you?
This chart, wow, it really says it all, doesn't it? It shows the incredible power of modern intensive care. Without it, the mortality rate for tetanus is over 50%. It's a coin toss. But with the full support of an ICU, we can drive that number all the way down to around 10%. It's a huge testament to what we do. But for the survivors, the journey is far from over. This is a long, slow road to recovery, often taking 4 to 6 weeks or even more of intense support. But here's the hopeful part. Recovery can be complete. People can get back to normal. We just can't forget the massive psychological toll of going through something so terrifying for so long. So there you have it. This whole review was based on some excellent articles from the British Journal of Anaesthesia and Anaesthesia Update. Thanks so much for joining us, and we wish you the very best of luck on your exams.